Dear students, we will discuss a topic which is uncommon, but as a surgeon, we will see that what this specimen is. Look at this. You can see the intestine here. There is a lesion here, nodular lesion here. So the good clearance is there on either margin. Probably small bowel resected specimen. Resection anastomosis done. Definitely, it's a pathological specimen. Fresh specimen, of course. This must be neoplastic condition. See that it's a small bowel tumor. Mostly this is malignant. So small bowel tumors are rare. Small bowel is the lengthiest part of the GI, around 6 meters, 6 meter length. But small bowel tumors are rare because rapid transit time, good immunological system, mucus rich in alkali, and detoxifying agents, more IgA. There are so many causes which I have mentioned here, the reasons why. And commonest malignant tumor, benign can occur like lipoma, neurofibroma, polyps can occur, which may precipitate intussusception, obstruction, hemorrhage, all the things can occur. And malignant, commonest is adenocarcinoma, next is carcinoid, next is lymphoma, next is GIST, all these things can occur. Now adenocarcinoma, small bowel adenocarcinoma, they are most aggressive, very, very aggressive adenocarcinoma. Colon adenocarcinoma, very good actually, very good prognosis. Whereas small bowel adenocarcinoma, very poor prognosis, very aggressive tumor. And next is carcinoid, that is also aggressive but not as like adenocarcinoma. Lymphoma is good. Once you do resect and treat chemotherapy, they do well. And GIST is definitely very good prognosis. So in the descending order, worse and better, good and better, like that it is. This one. Adenocarcinoma is the commonest thing. Now, this presentation often left unnoticed because vague discomfort is a very common thing. And only often it is diagnosed, identified by sonology or CT scan. And eventually once go for obstruction, they will have features of obstruction, vomiting, pain, colic pain and so on. Sometimes they present with metastatic disease, liver spread, liver ascites, systemic spread and so on. This may be unnoticed at all, primary. Only eventually when you do evaluation, it will be unnoticed. It will be noticed, identified. So there is a problem with the small bowel tumor. Small bowel tumors are rare, but when they are malignant, they are very, very aggressive, especially adenocarcinoma. Remember, there is a point which you have to remember. Compared to colonic adenocarcinoma, which got a very good prognosis, you can achieve a cure. It is not so if it happens in the small bowel, but GIST is different. GIST has got a very good prognosis. You got imatinib and related drugs, which will definitely give a very good prognosis and prolong the life as such. And all these features, loss of appetite, weight loss, vague discomfort, bleeding can occur, hematoxesia can occur, and obstruction can occur. So different presentation, perforation can occur, and peritonitis, and CT abdomen, CT enteroclysis, small bowel endoscope, push endoscope, but biopsy can't take in small bowel. Capsule endoscope you can do, again you can't take biopsy, you can't be sure where exactly it is. So finally it is difficult to diagnose, evaluate, and difficult to identify. That's important thing. When they present with the acute presentation, then or CT, once it confirms, treatment is resection anastomosis and send for the marker, ISC marker, to differentiate whether it is a dedifferentiated adenocarcinoma and lymphoma. Many times initial histology is adenocarcinoma, but after ISC marker it becomes lymphoma. That's very good. Sometimes it is a vice versa. Initial histology it is lymphoma, eventual marker shows that is adenocarcinoma. That is worse prognosis. So ISC markers are very, very essential to do in this patient to finalize the final pathological diagnosis. That is important. And eventual chemotherapy and targeted therapy is very, very useful. Proper regular follow-up. Sometimes PET CT is required. Regular CT scan, abdomen evaluation, clinical examination also important. To get worst prognosis for adenocarcinoma, then carcinoid, then lymphoma. GIST has got a best prognosis. Read my clinical manual of surgery chapter. It goes very in detail about the small bowel tumor, which is a long, it is a short note for UGs. It is a main question for postgraduates. And acute presentation is a common thing. And resection is the treatment of choice. So students, subscribe my YouTube channel, SRB Surgery Insight, and share with your friends and colleagues, and press the bell and update your surgical knowledge on day-to-day, daily basis with instrument, specimen, operative procedure, illustrations, and clinical cases importantly. And also join live session whenever possible, one of our clinical sessions of case presentation and it will help you to get a certificate for your future career. And also purchase my manual of surgery and clinical method, because in detail about the different surgery and examination, which is more than sufficient to have a proper surgical knowledge. Answer the MCQs. Feigelman classification is used in A, B, C, D. Put the right answer. I appreciate your answer in the comment box. And minimum small bowel length required to avoid short gut syndrome. Short gut syndrome is a short note for you, or MCQ questions. Oxy they will ask. So you should know A, B, C, D. Put the right answer in the comment box. I appreciate your answer. Quotation of the day is: be in the world but unaffected by negativity. Negativity will be there in all way of life, but ignore the negativity. Be positive and go ahead with your life. That is the most important thing, especially in surgery, because many times you lose patient, then don't get deterred, because there are ups and downs in surgical profession, surgical career. So it's a rather challenging career actually. So this quotation holds very good for that. And always subscribe my YouTube channel, and also go through my manual of surgery and clinical method surgery. So students, I hope you have understood this lecture very well. Thank you so much.